Hello everyone, my name is Osama Daoud. I'm a second year medical student, and in today's lecture, we will discuss pancreatic secretions. Inshallah, it's going to be an easy lecture, simple, straightforward, no complicated or complex uh, concepts. So let's start. Just give me 1 second. Okay. The objectives we will be going to discuss the pancreatic juice secretions, the composition, the regulation, what are the enzymes, and any exocrine deficiencies or diseases. Starting off with the basic anatomy of the pancreas, we know we have two types of glands, endocrine and exocrine. The difference is endocrine is the glands that produce their secretions straight into the bloodstream, while exocrine are the glands that secrete through a duct. And there are very few glands that have a mix of both, and the pancreas is one of them. From the endocrine secretions, we know we have the hormones, two main hormones, insulin and glucagon. And for the exocrine secretions, we have the enzymes and bicarbonate that we are going to discuss today. Here, as you can see, we have mainly three types of cells that we are going to discuss. First of all, we have this lumen or duct with the ductal cells. Those cells produce bicarbonate. Their main function is producing aqueous solution of bicarbonate. And we have those SNR cells. Those are the endocrine glands, you can say. Those secrete the enzymes. And then third of all, and lastly, the islet cells or islet of Langerhans. Those aren't really important for today's lecture. We're going to discuss them in endorepro. Those are the endocrine glands that produce insulin and glucagon. Again, ductal cells, SNR exocrine glands, and islets of Langerhans endocrine glands. SNR cells will produce their enzymes into the lumen. The ductal cells will produce the bicarbonate and the aqueous solution also into the lumen and reabsorb some stuff that we are going to discuss in the next slide. The production of pancreatic secretions. As we can see, طبعا, before we get into the bullet points, let's clarify it here on this small diagram. طبعا, this is the acinar cell, let's say, and this is the duct and the ductal cell. One important note to take care of, the pancreatic fluid is isotonic in comparison to plasma. What does this mean? The iron concentration in the pancreatic fluid is equal to that of the plasma. Why is that? We have here the capillaries, blood vessels around the cells, providing them nutrients, blood, oxygen, whatever. The pancreatic cells have high water permeability. So wherever there is ions, water will follow. So basically, the ions, when they diffuse into the cell from the plasma, from the capillaries, water follows them, which means the concentration doesn't change, which means the fluid has the exact same concentration of ions as the plasma. So it creates an isotonic fluid. This point differentiates the pancreatic fluid from other secreted fluids. As you can see also here in the duct, we said the ductal cells. Let me draw these boxes. Let's assume they are the cells. The main product is bicarbonate, HCO3. When HCO3 is secreted into the duct, into the lumen, the cells will secrete bicarbonate, but in return, they are going to absorb chloride. So basically, bicarbonate and chloride are opposite. When bicarb increases, chloride decreases. And when chloride increases, bicarb decreases. They're never the same. They're exactly opposite. Starting with the first point, secretin released in the intestinal phase by cells as a response to low pH by stomach. So basically, the main stimulus for bicarbonate and for the aqueous solution to be produced and secreted is secretin. But secretin is stimulated by what? What is the cause of secreting secretin? In the intestinal phase, as we know, going down from the stomach, we have the stomach here, let's say, going down to the duodenum. the digested food that we ate and got digested is called chyme. The stomach's environment is acidic, so the chyme has an acidic environment. So once the chyme is transmitted down from the stomach down to the duodenum, there's going to be a change in the pH environment of the duodenum, going to a little bit more acidic environment. And this acidity and the low pH is the stimulus for secretin to be secreted. The S cells of the duodenum will secrete secretin in response to the acidic environment and the low pH induced by chyme, by the food from the stomach. So the low pH induces the S cells to produce secretin. But why is that? Secretin will come and it will stimulate the ductal cells to produce more bicarbonate. What this will do? What does this do to the chyme or the food or in the duodenum? This will neutralize the acidity that was induced by chyme. So basically, you have acid, you release secretin, you release bicarbonate. So bicarbonate can again neutralize this acid. So why do we need to neutralize this acid? For two main reasons. The first point is to protect the duodenum because it has less protective mechanisms going in comparison to the stomach, cannot tolerate acidity. And the second point, and which is the main point, it is the optimum pH of pancreatic enzymes. Pancreatic enzymes have an optimum pH of alkaline environment, which is around 8, 8.2 in that range. So to produce the best effect by pancreatic fluid and enzymes, we need an alkaline environment. Fluid secreted is isotonic due to the high water permeability. We have talked about that. The fluid composition, we have bicarbonate secretion increases and the chloride gets reabsorbed. We can here in this graph, in this curve, we can see as secretin is produced, the rate of secretion, first of all, increases, goes from 100, almost 100 milliliters per hour, up to 400, 4 times increases. And the ions, sodium and potassium, do not change because we said it is isotonic. Chloride changes because it gets reabsorbed. There are special channels for chloride to get reabsorbed. That's why it changes, and sodium and potassium do not. And bicarbonate gets secreted. So as we can see, bicarbonate, the curve goes up as it's getting secreted, and chloride concentration goes down as it is getting reabsorbed. And we can see here up the osmolality of the fluid does not change, but the pH changes. The pH increases as you are secreting more bicarbonate, inducing more alkaline environment, neutralizing the chyme. Here, a very important number, 8.2. In the intestinal phase, in summary, in the intestinal phase, we have more ductal secretions than acinar secretions. What are the acinar secretions? Enzymes. What are the ductal secretions? Bicarbonate. So we have more ductal secretions. And ductal fluid is clear, colorless, alkaline, and isotonic. This is basically the ductal fluid. And what is it basically? The normal plasma serum ions, as well as water, as well as increased bicarbonate. And that's basically the ductal fluid. Nothing much to it. Going next to the phases of secretion. We have 3 phases, the same old 3 phases, nothing new. The cephalic, gastric, and intestinal. طبعا the intestinal phase affects pancreatic secretions the most because of secretin and CCK. But the cephalic and gastric phases affect also the pancreas to a lesser extent using the vagovagal reflexes and basically using neurotransmitters. Mainly it is using acetylcholine and the vagovagal reflex causing enzyme secretions, and it increases the acinar secretions. Sometimes it is VIP, sometimes it is GRP, but mostly it is acetylcholine in the vagovagal reflex. بس طبعا all of them are neurotransmitters used. Also note that the sympathetic innervation also induces enzyme secretion in the pancreas. As we said again, mainly it is the intestinal phase. Low pH induces secretin by S cells, and cholecystokinin CCK is induced by amino acids mainly and fats to a lesser extent, and is produced from eye cells, and both of them from the duodenum. Going next to the regulation of producing secreting, regulation of the secretions. طبعا we do not need to know details. We don't need to go into the cellular signaling and stuff like that. No need to go into details. Just know the general idea. We have a stimulus for the S cells. It's the protons, H plus acid. And for the I cell, it is the amino acids. The S cells use the cyclic AMP, PKA phosphorylation pathway. No need to know details. Produces secretin. Secretin will induce bicarb production through ductal cells. For the eye cell, it is induced by amino acids. There are certain receptors on the cells that will search for amino acids or for protons, for example, on the S cell. And once they bind, they're going to induce the signaling pathway. For the eye cell, we have the IP3 pathway inducing calcium release. Calcium release will cause the effect. No need to go into deep details. CCK is released, induces enzyme production by acinar cells. طبعا as we said, vagovagal reflex acetylcholine. Acetylcholine when produced potentiates the effect of amino acids and increases CCK even more, the production of CCK and enzyme production even more. As we said, we have VIP, we have GRP, we have acetylcholine through the muscarinic receptors. All of these are neurotransmitters. And we have CCK through the calcium pathway. طبعا one thing to know that the cells pre-synthesize the enzymes, which means before having stimulus, the cell is already working, the cell is already producing enzymes, and it will store them in vesicles, in granules. Those granules will release their contents once the stimulus has been received or stimulated either by phosphorylation, calcium release, whatever. They will go bind to the granule, tell the granule, go release your content. There is food we need to digest. As we said, pre-synthesized and stored. CCK binding mobilizes calcium. Calcium moves to the granules, is released by the initial stimulus. VIP, acetylcholine, and GRP are all examples of neurotransmitters. This was wrapping up the regulation part. It's really simple, nothing much to it. Going next with the enzymes itself. Zymogens and their classes. What is a zymogen? A zymogen basically is an inactive form of a protein. I have the protein, but it is inactive. The active site isn't still confirmed أو it's يعني full form and uncovered to bind. لا. The zymogens are still inactive enzymes that need to be activated to be able to bind to a substrate and work. Most enzymes in the pancreas are in their inactive form. I'm sorry, it's not all, it's most of them. Fix this. Because why are they in their inactive form؟ ليش ما يكونوا active خلاص وريح حالي؟ It doesn't work like that. Imagine the pancreas as a storage room or a storage bag for enzymes. Imagine if all types of enzymes were there, all of them are active. Lipases, amylases, proteases, حرفيا every single type of macronutrient could be lysed or could be broken down, by those enzymes. Big problem. We're gonna get into the loop of autodigestion and autoimmune diseases and chronic inflammation, and that's gonna make big problems. It's gonna get into diseases. We will discuss chronic pancreatitis in one of the case studies the doctor put. So we'll talk about it later. طيب, damn enzymes are inactive. There should be a way to activate them. How do we activate those enzymes? We have two ways, or three ways, let's say, two main, one secondary. The first main way is through enterokinase enzyme. What is this enzyme? This is the lumen of the duodenum. Here we have the cells, the epithelial cells. Here we have the microvilli. These microvilli are called the brush border. This enterokinase is an enzyme that is fixed and present on the brush border. It is present on the microvilli, on the brush borders, and it's fixed there. Why is it fixed there? So once the pancreas releases its enzymes and reaches the lining of the duodenum, the enterokinase starts activating the lytic enzymes. This is the main way. The secondary way is through trypsin. Enterokinase activates trypsin. We have trypsinogen, the inactive form of trypsin. It gets activated into trypsin by enterokinase. After trypsinogen is activated, the active form called trypsin will go and activates all the other proteolytic enzymes. Yani trypsinogen turns to trypsin, then trypsin will go, okay, ribonucleases activate, decarbonucleases, yalla, reaction activate, chemotrypsinogen activate, proteolases activate, procarboxypeptidases activate. Literally every type trypsin can activate most types of proteolytic enzymes. The second way, it's not really activating, it's more of giving the optimum environment for enzymes, and it's through the alkaline medium that we have talked about already. And it is used for the lipolytic enzymes, basically lipase, and for amylase. It sets an alkaline environment for them, for the optimum pH yani, to achieve the best efficiency and best activity of the enzyme. Yes, we have all types of enzymes, حرفيا. Amylases for carbs, proteases for proteins, lipases for lipids, decarboxynucleases, DNA, ribonucleases for RNA. حرفيا, we can break down every single type of anything, حرفيا. So that's why when we have some chronic diseases, obstruction, autodigestion problems, the pancreas eats itself inside out, and this creates serious problems. We're done. Literally, that was it. This slide is a summary for the feedback loop. We have food, chyme getting in. pH is acidic. It stimulates secretin. Amino acids from the digested proteins stimulate CCK. Secretin releases bicarb, CCK releases enzymes, and CCK also sometimes potentiates secretin for bicarb production. Enzymes and fluids digest the food further, and repeat. This is the summary slide. We are done with this. Now let's talk about the cases. Case study number 1, pancreatitis. 1 second, please. Sorry. Pancreatitis. I did not put the whole case, and it's too much. It's just any talk سوالف. You can read it alone. But I'm here to highlight most important stuff for you out of the case. For case study 1, I think it was like a 38-year-old male, alcoholic, coming in with pain and stuff. Point number 1 is that he was an alcoholic. Keep this in mind. We're gonna return to it. The symptoms. He had epigastric pain, upper abdomen pain, radiating back to his back. The pain gets worse when he's supine or lying on his back, and alleviated when he sits up and leans forward. The upper back shows tenderness. I'm sorry, upper abdomen shows the tenderness and distension. He has a distended abdomen. Those were his clinical symptoms. Going to his lab work, he showed extremely elevated serum lipase and amylase, which shouldn't be, which means the pancreas enzymes are out. The enzymes are being عم بتسربوا لبرا عم بيطلعوا. They're getting secreted accidentally. The cells are lysing and releasing their contents of enzymes. We have elevated BUN and elevated glucose. The elevated BUN also, we're going to get back to it in a second. We have leukocytosis. What does it mean? Leukocytosis is elevated levels of white blood cells, leukocytes, neutrophils, whatever, which is an indicative of inflammation. Inflammation, what does it mean? Basically, inflammation is a sign of, and okay, there is damage. The body is trying to compensate. The body is trying to fix this problem. So there's inflammation. There's WB cells. Okay, going next, we have proteinuria. Proteinuria is basically protein in urine. I'm going to get back to it with BUN. BUN is blood urea nitrate, by the way. And lastly, the patient had a stool sample and it showed fatty stool, steatorrhea. Let's go to the case breakdown and explain these points one by one and dissect this case. Let's talk بالأول about what's normal and what's abnormal. For releasing enzymes, the normal mechanism is that the enzymes are produced, secreted through ducts, and the enzymes are zymogens. Once they are in the lumen, they will get activated by enterokinase, trypsin, alkaline medium, whatever mechanism they get activated in. That is what's usually normal. The enzymes don't get activated unless they left the pancreas. Now, in such a case, we said he was an alcoholic. The alcohol left cellular damage in the pancreas. The alcohol he consumed, he's a chronic consumer. He binged alcohol. That resulted in pancreas damage. But this doesn't happen over one binge or overnight. This is the result of chronic binging, time after time after time, till the damage was unrepairable and the inflammation was too bad. The cells started lysing and releasing their contents while the enzymes are released. And as we said, there are some enzymes that are active, lipases and amylases. And who knows, proteases can get activated in such cases. So basically, the enzymes are released into the pancreas, they are activated, and the pancreas starts autodigestion and eating itself inside out. As we said, leukocytosis is indicative of inflammation. We have now the one. I'm sorry, one thing we forgot to discuss is the patient's vitals. He showed elevated temperature of 39 degrees Celsius. He showed tachycardia of 98 beats per minute. His respiratory rate was 17, and he showed blood pressure of 95/70. Okay, starting with the temperature, it's a sign of inflammation طبعا, chronic inflammation or acute حتى. Temperature and heat is one of the main points of inflammation. Going next to the blood pressure. It shows low blood pressure of 95/70. Why? The case said that the patient was vomiting and was profusely sweating. What is sweat and vomit, basically? It's fluids, which means there's fluid loss. Fluid loss means the volume of blood has decreased. We're losing volume. This decrease of volume causes a drop in blood pressure. So the low blood pressure will cause a reflex tachycardia, where the heart will be trying to compensate, pushing more blood beating more and harder to compensate this low blood pressure. So now we have linked the low blood pressure to the tachycardia. It is because of losing volume. Lastly, we have the proteinuria and the high blood urea nitrate. This could be due to a renal malfunction in filtration because we have decreased blood flow due to the low blood pressure. So the GFR decreases. If you remember the glomerular filtration rate from renal, the GFR decreases and we have filtration problems. We could have some malfunction of the kidneys, and in more complicated cases, we could have kidney damage. If we had decreased even more in decreased blood flow or something, we could have acute kidney injury, AKI, or whatever complications we can have for the kidneys. It's not our topic. This will cause filtration problems basically. So the urea nitrate in the blood increases, it's not getting filtered, and the proteins, instead of not getting filtered, they are crossing the barrier, they are getting into the filtrate, and they are produced in urine, which is a bad indicative also. So this is basically pancreatitis, chronic inflammation of the pancreas. The cause here is alcohol damage to the cells, causing autodigestion by enzymes. It can be caused by viruses, infection, whatever. The cause here is autodigestion by enzymes due to alcohol damage. Going next, case study number 2, we have the Zollinger-Ellison syndrome. To give you a brief description of what this is, Zollinger-Ellison syndrome is basically when you have a tumor, specifically a gastrinoma in the stomach, a gastrinoma, either single or multiple, and those gastrinomas are producing too much gastrin hormone. This gastrin is leading to increased acid production, and this acid production is causing duodenal ulceration, stomach ulceration, but especially in the duodenum. And these tumors are usually ectopic, which means they are not present in the stomach. They're usually present in the pancreas or sometimes in the duodenum, but most commonly in the pancreas. Again, I'll not read the full case. You can read it by own from the slides. I'll highlight only the main points. Starting with the clinical presentation, I think it was a 43-year-old patient came in with peptic ulcer symptoms. The patient had recurrent duodenal ulcerations for the past 5 years, mid-epigastric burning sensation pain, and this pain is exacerbated by an empty stomach, maybe in the morning, not eating for a while, exacerbates the symptoms, and it is alleviating by eating, by having a full stomach, it is alleviated. طبعا quickly noting about this point, why is this happening? When you have direct contact by the acid to the stomach, is going to cause irritation by an empty stomach. But if there is food, it's going to be a barrier between the acid and the stomach. But this decreases the irritation. And steatorrhea, fatty stool, is also a symptom that could be there. I think they mentioned that later on in the case, so I put it. And then we have the lab work. Let's discuss the lab work. The markers in the lab work are very important, and the doctor stressed about them. So it's good to know them. First of all, the patient had extremely elevated gastrin secretion. I'm sorry, this ant is extra. Remove it. Extremely elevated gastrin secretion. The basal gastrin acid secretion is also through the roof, 10 times the normal range, which means the gastrin is causing elevated acid secretion, but because this gastrin is being from an ectopic tissue, it's not responding to the negative feedback loop. Basically, what is an ectopic tissue? is our ectopic secretions are normal body secretions from abnormal tissues أو normal يعني tissues in abnormal locations. And it's not supposed to be here, not supposed to be producing this. But it's normal. It's a part of the body, but it's gastrin is a normal hormone that's being produced by an abnormal tissue. That's why it's an ectopic secretion. Going to the third point, the negative pentagastrin stimulation test. Basically, pentagastrin is a type of synthetic gastrin. This stimulation test is when you give pentagastrin, the acid secretion, the basal gastrin acid secretion, should increase. But here it's negative, which means it doesn't increase. The stimulation test doesn't increase acid secretion, which points that it's already extremely high. It cannot increase more أصلا. يعني it's through the roof. This is not a good indicative when it happens. We have next the secretin stimulation test. Basically, when you give secretin, when you stimulate secretin, it should it should inhibit gastrin. Secretin increased, gastrin should be inhibited. They work opposite to each other. Secretin inhibits gastrin. But here, the secretin stimulation test causes elevated gastrin even more. This is a sign of ectopic tissue or tumors producing gastrin. It's abnormal secretion. فأكيد it will not obey or be obedient to the normal negative feedback loop. Okay, going next to the case breakdown in details to dissect it. One thing the doctor stressed on is this point. The stuff that stimulate acid secretion and inhibit them. Know them by heart. You have three main ones. You have gastrin, increases acid, physical distension of the stomach by food, mechanoreceptors send stimulus, acid secretion, and paracrine stimulus through histamine. Cell-to-cell paracrine stimulation by histamine increases H+. And last one worth of noting is the neurotransmission طبعا by acetylcholine through the vagovagal reflex. And for the inhibition, we have the two S's, secretin and somatostatin. طبعا somatostatin inhibits everything يعني know it by heart. As we said, the secretin stimulation test elevates gastrin, which is an indicative or characteristic of tumor cells, mostly in the pancreas, which is a complication of gastrinoma. As we said, gastrinomas, tumors in the pancreas, in the duodenum, all of them could cause this Zollinger-Ellison syndrome. So the tumor should be secreting gastrin to be called Zollinger-Ellison syndrome. Sorry. So this is an ectopic gastrin secretion, as we said. And steatorrhea. Steatorrhea could be caused by multiple causes. First of all, if the tumor is obstructing the pancreatic duct, not allowing the secretions to reach. That's one. It gets excreted in stool in the fats. Second, inactive enzymes or deficient enzymes, maybe inactive lipases مثلا, the enzymes cannot break down, or high acidity causing malfunction of bile acids, cannot bind to fats, so the lipases cannot break down. That's three. And the last one, the last problem is damaged intestinal mucosa. Either enterokinases, brush borders are damaged, cannot activate. Oh, I'm sorry, this doesn't relate. That's for proteins. بس إنه brush borders are damaged, microvilli are damaged, poor absorption. The surface area of absorption decreases so much, you cannot absorb the lipids, so they get excreted in a stool. And the last point we need to talk about and discuss is the duodenal ulcers caused by stomach acidity. When you have too much gastrin, too much acid produced, the environment of the stomach gets very acidic. طبعا the stomach can tolerate شوي, it has thick mucus layer, thick wall, has some physical protective mechanisms, chemical protective mechanisms, unlike the duodenum. The duodenum has less protective mechanisms, which means it can tolerate acidity less, cannot tolerate it as much as the stomach. This causes ulcerations, causes damage, and causes duodenal ulcers at the end. We are done with the case studies. I hope everything is clear. Let's start with practice questions to make sure everyone is clear about everything. I'll be showing you the questions. I'll be showing you the questions. I'll give you a moment to pause the video, solve it, put your answer, and then continue to see the explanation. Starting with question number 1, which of the following hormones is released by the presence of fat and protein in small intestines and has a major effect to decrease the gastric emptying? I'm sorry. Before going into the questions, there's one point I remember it's important I forgot to mention about the endocrine and exocrine glands. The islets of Langerhans create up to only 3% of the total pancreas mass. Only 3% almost is endocrine glands, and the rest is exocrine glands. This is one important thing to know. I'm really sorry I forgot to mention. Going back to the questions. Which of the following hormones is released by presence of fat and protein in small intestine and has a major effect to decrease gastric emptying? Out of all of these, which enzyme, which hormone, substance decreases gastric emptying and is stimulated by fats and proteins? We mentioned it at the very beginning. Pause a second and solve it, then come back. Okay, basically أكيد not secretin, motilin, or gastrin. Not even GIP. And from fat and protein, you can rule out everything. It's cholecystokine. This is a recall question basically. Protein, fat, cholecystokine. Going next, a group of researchers studying the function and feature of pancreatic exocrine secretions. They take samples of pancreatic secretions at various stages in test subjects, including 30 minutes after eating a meal and who have fasted. Which of the following is true regarding pancreatic exocrine secretion? Pause it for a second. Okay. The pancreatic fluid is hypotonic. Is it hypotonic? No. It's isotonic because it's water permeable. Chloride and bicarbonate concentrations are higher. No, we said chloride gets reabsorbed. Bicarbonate concentration is higher. This could be correct. Let's keep it till the end. Chloride concentration is higher. No, again, we said chloride gets reabsorbed. All hormones secreted by pancreatic acinar cells are inactive and activated in the intestines. First of all, it's not hormones, it should be enzymes. Second of all, we said lipases and amylases are active but need an alkaline medium. So we are left with C. It's the only correct option. Bicarbonate increases during higher flow rates. Next, cystic fibrosis is the most common cause of pancreatitis in children. Which of the following best explains the mechanism of cystic fibrosis? Please pause for a second. Okay, what is cystic fibrosis? I do not want to get into the details, the malfunctioning chloride channel and whatsoever. But basically, cystic fibrosis is when you have a tract that has mucus productions, it's usually lining the tract for lubrication, for protection, for whatever. When you have cystic fibrosis, this mucus secretions increase so much that they almost, يعني, cover it all and block the tract. When the pancreatic duct is blocked, the enzymes cannot leave into the lumen. They are active and they are انحشروا and are blocked. At this point, let's say this is the pancreas, this is the duct, all the enzymes are being here. It's going to cause a buildup inside the pancreas, which is going to cause autodigestion. Next, a patient is experiencing steatorrhea. Tests show that the enterohepatic circulation of bile salts is normal. Bile salts are normal. Any fat is soluble. Absorption of orally administered glucose is normal. Any normal mucosa. Disorder in which of the following is most likely to be present? Pause it for a second. Okay. As we said, bile salts are normal, fats and lipids are soluble. Glucose absorption is normal. Brush borders are normal. We cancel the brush border. We cancel out the surface area. And then we have the motility. It has nothing to do with the case. We are left with pancreatic enzyme secretion. The fats are soluble and have a large surface area by bile salts, and the absorption is normal. The only deficient thing is going to be the enzyme itself breaking it down. So the answer is D. What is the role of cholecystokinin in fat digestion? This is an easy question. Pause it. Okay. As we said, we have two hormones, CCK and secretin. This enhances or stimulates bicarbonate, and this stimulates enzymes. So, what is the answer? Does it inhibit gallbladder contractions? No. Inhibits effect of secretin? No. Increases strength of gastric peristalsis? No. Activates proteolytic enzymes? Enzymes, maybe, but proteolytic or activates. No, it does not activate them. Enterokinase and trypsin activates them. So the answer is C. Stimulates the secretion of pancreatic lipase. Going next to the next question. Researchers measure bicarbonate content of duodenal aspirates and plot these values as a function of blood level hormone. The hormone studied by the researchers is most likely one produced in which organ? Pause the video. Sorry. Okay. Basically, the question is saying we have a hormone produced by organ X. This hormone, when it functions, it increases the bicarbonate secretion. What hormone does that? Secretin. What cells produce secretin? S cells. Where are the S cells that increase bicarb concentration are present? In the duodenum. Exactly. So the answer is B. This is the last question. Which of the following factors or combination of factors is responsible for activation of proteolytic enzymes secreted by pancreas? Proteolytic enzyme activation, as we said, so directly enterokinase and trypsin. Does pepsin activate them? First of all, no, it's in the stomach. Second of all, it doesn't. It's the job of trypsin. HCl, acid. Does acid activate the pancreatic enzymes? No. We need an alkaline environment. So we are left with trypsin and enterokinase. So search for an option that says yes, yes, here, and then no, no. So the answer is number 2, B. Here's the bubble sheet with the answers. You can solve them alone. and check the bubble sheet. Thank you, everyone. Thank you so much for watching. We are done with the lecture. I hope it was an easy lecture. I hope it went smoothly. You can scan the QR code and give us your feedback so we can work on the sessions for next times, inshallah, and make them better and better. Thank you for watching. If you have any questions, if anything is not clear, these are my contacts. Here's my email, and you can text me on WhatsApp or email me. Thank you for watching, and goodbye.